because you're not alone. Like everyone goes through it. It's a rare woman that does not notice the menopause change.
Yeah.
Yeah.
Everybody goes through it,
Yep.
right? Not
Yeah.
everybody may have a child, but every woman will go through menopause.
Right. Right.
You have to go through menopause, die, and pay taxes.
Yes. Hello.
Hello.
Welcome to the cool Vagine.
Yes.
Love the name.
I know.
I know, right? And you know what, Siri on my Apple phone, it never ever puts Vagine. It puts like every other word. I'm like, do you not know what it means? It's vagina.
We spelled it enough times, right?
How did you guys come up with the name?
So I would always say vagine. I don't know, like
Yeah.
shake your vagines. I don't know why. It's like I would just be
Yeah, I don't
saying
even know
it,
where it came from. And I
right?
kind of thought the full Monty, like your butt, like
Yeah.
kind of like the full.
I just love it. It's like calling Target Target. It just adds
Yes.
to the whole thing.
Yep.
Yeah, we just wanted to be like have unfiltered conversations about all transitions of a woman's life,
Yes.
like
Yes.
menopause, which is, I feel like this is our menopause week. I'm so
It is. We're
excited.
doing a lot with
And
that, which is good. Yes. And before
yes,
we start, go Birds. We won the Super Bowl.
no birds. Yeah.
Or, yeah, I do want to say for your viewers that I normally look a little bit more professional, but today in
Have it.
Yeah.
Right?
today for my Eagles green.
Yes.
Yes.
So speaking of, Kristen, you're going to introduce.
Yes. So we have here the esteemed Dr. Kim Einhorn.
Yay!
Thank you so much for
Thank you so
taking the time
much.
to be here. And she is a board certified OBGYN and fellow of the College of Obstetricians and Gynecologists with 20 years of experience with full scope OBGYN. Full scope. I just thought scope, and I'm like, oh, I probably got scoped. Definitely.
Yeah, many times.
At Lankenau Medical Center and passionate about resident education. I know Catherine mentioned that you went and spoke to them.
Teach them all about hormone therapy and menopause care.
Yeah. And so she is a certified menopause provider from the North American Menopause Society. She's been repeatedly recognized as one of the top docs of the main line here in Philadelphia. And we have discussed this deeply, a passion for the care of menopausal and perimenopausal women.
Yes.
And coming this September, she is opening a practice
Yay.
in the Philadelphia suburbs, the Menopause Collective.
So
tell us a
exciting.
little bit about that, because that's super
Yeah.
exciting.
So exciting.
We're
I know
going to have it.
this is so exciting for me because this is actually, I never dreamed that I would do this. I was in the same practice since I graduated from residency. I did my residency at Thomas Jefferson. I'm a Philly girl, and I have been at the same practice for about 18 years. And for many reasons, we decided to kind of close that practice, long story, but it is giving me the opportunity to do what I've always dreamed about and what I've become passionate about as I've gotten into midlife and gotten older, which is perimenopause and menopause care. And this is an area that has just been kind of overlooked and brushed to the side. And I think mostly not because we as gynecologists don't care, but because we've been undereducated in the field of menopause and perimenopause because it's been under researched. And when we don't have the tools and the knowledge to take care of it, we feel just very unprepared. And it was always at that visit that we would dread. I'm going to put myself in that same boat because before I really did take it upon myself to delve deeper into the field and become more knowledgeable, I was one of those providers, like many menopause providers, that just didn't have that knowledge. And when I had a menopause visit coming up, I, had like a panic in my heart because I, didn't know how I could help these women that are so in need. So as I went into perimenopause myself and started looking for all these answers, I found that, this is a field, a special group of women that really have so many different concerns and health issues going on that without too much, like we can really, really help them change the course of their lives, change the course of their health. And they're just so, I call it just like instant gratification. So, we really get that with the menopausal women because there's very simple things that we can just do to help them feel better emotionally, physically, medically, and it really makes a huge difference. And I love that. So as I got older and my patients aged with me, I found that like almost all my visits started becoming perimenopause visits, and I became very adept at taking care of them, became certified. And now I want to focus purely on that. So that's what this dream practice is. It's a practice that is going to like really just take on women in their midlife and their issues, their, not only just their medical hormonal issues, but their weight issues and their physical fitness goals and their nutritional goals and their emotional and psychological health as well. So it's going to be like kind of a comprehensive, holistic view of care.
Right. Because I
Yeah,
feel like,
I love that.
yeah, and I feel like that is
Collective.
menopause, like, and a lot of people don't know that. And so in that, speaking of menopause and all that, but what do you think is the most common misconception that people have about it?
I think there are so many. And one is that, you just have to get through it, which is, and suffer through it, which is really not the case. I mean, I think it was unfortunately the case for many years, for almost the last 20 years. We as gynecologists were under so many misconceptions about what hormone replacement therapy would do, the dangers of it, which really are not really there, not really true for the most part. Most women can take hormone replacement therapy very safely, and it has so many benefits to them. But, we've been taught that it really only had risks and was going to give you breast cancer and give you a heart disease. And all these things are really, really not true. And finally are actually reaching that mainstream media where I used to have women coming into me and they would tell me they're suffering, list off 5 different terrible symptoms, X, Y, and Z. And I'd say, well, let's talk about hormones. And absolutely not. Like couldn't convince them come hell or high water that they could safely go on hormones. And now, thanks in large part to social media and other different things that have finally reached exactly. And things that have actually reached the New York Times and things like that women come to me with their symptoms now saying, let's talk about hormones. And I couldn't be happier about all that. So I think the biggest myth is that hormones are dangerous.
Yes.
And, and I can't go on them and I just have to kind of get through it. And that's absolutely not true. There is so much, your doctor can do hormonally and non-hormonally to really help you through it. But, really like hitting home, I spend a lot of time on my Instagram really talking about trying to bust the myths about the dangers of hormones.
And that's so true, 100%, because I know it's a generational thing because my parents and all that, they're like, no, you can't take hormones. Oh no, they're so bad, but it's not their fault either because they weren't educated. And there wasn't enough, like you said, information about it. And now there is, and it's great and it's helping.
Yeah.
Yes. I mean, we have just a little on the history of the research and the literature. Prior to, there was a little bit of a landmark year for women's health and hormones, which was 2002 when a study called the Women's Health Initiative came out. And prior to that, there was a lot of what we call observational data that really did point to the benefits of hormones, meaning we thought it could reduce your cardiovascular risk. It certainly helped with osteoporosis. We didn't worry about it causing breast cancer. And all these studies really pointed towards the health benefits, not only just quality of life, but health benefits to being on hormone replacement therapy. And, some of the data was conflicting, which led the National Institute of Health to really create this very large, what we call randomized controlled trial called the Women's Health Initiative, or we call it the WHI. And the WHI was this study that actually was stopped early because due to their statistical analysis, they found that there was a increased risk of breast cancer, which was very overblown by the media. And it all has to do with ways that we report risk. But really, when you look at the numbers, it wasn't a high risk. It was really just less than 1 extra case of breast cancer per 1,000 women users per year. So that's not a high risk, but it really got overblown in the media. And really because of this, and they reported increased risk of cardiovascular disease, also low numbers, for about 20 years, everyone went off hormone therapy. I mean, if you say breast cancer to women with good reason, everyone's going to be scared, doctors and patients. So women for about 20 years, didn't use hormone replacement therapy. And there's a lot of data out there that suggests that mortality risks went up, morbidity, complication risk went up for those 20 years. And now again, hopefully I'm hoping that tide has, turned and we're going to be able to get the information out there that this really was data for many reasons was not applicable to the young woman that starts hormone replacement therapy at the time when they normally would need it, in their early 50s, late 50s, not in their mid 60s, which was the average age of the woman that was in the WHI study. Exactly.
Right.
And
so
we do have a lot of data that, shows that now that it's actually fine, especially when started in that younger window.
So I saw it too. I wanted to ask you this on Instagram, and there's just so much information out there. But they also said that they did not use bio or body identical hormones.
Right.
For that study.
So for that study, now back in the time when that study was done, we really didn't have the same kind of options of hormone therapy as we do now. Now we have, I mean, when I do the lecture for the residents and for, other doctors around, I have a whole slide with like 20 different options and kinds of estrogen and kinds of progesterone. But back then, and at the time of the study, there was really one main option for estrogen, which was called conjugated equine estrogen, or CEE.
Horse, right?
Right. It's called Premarin, which actually, stands for, it's kind of an acronym combined for like pregnant mare urine. And it's not, the horses were treated kindly. That's a myth, that they didn't abuse horses to get the estrogen from pregnant mare urine, but that was a very bioavailable source of estrogen at the time. And pharma learned how to kind of harness that. And so it was CE, and then the progesterone used was called medroxyprogesterone acetate, or M. And that was what they used then. And what we use now is what we call bioidentical, which really means it's the exact same molecule that our body makes. So it's bioidentical estrogen, called estradiol, and bioidentical progesterone, called Prometrium, is the brand name now. And a lot of the studies have shown now that really the bioidentical estrogen and progesterone potentially don't carry these same risks as far as breast cancer goes that the CE and the MP did. And actually, just to clarify further, the estrogen component in the WHI study, there was two arms. One looked at estrogen alone for women that didn't have a uterus, and for women that did have a uterus, they were put on estrogen and progesterone. And the estrogen alone arm actually showed a decreased risk of breast cancer by about 40%. So we don't actually think it's the estrogen really that even causes the increased risk of breast cancer. If anything, it might be either the combination or just the progesterone alone. And the MPA does potentially carries an increased risk of breast cancer. So we don't use that kind of progesterone anyway, but we really do need more studies to really evaluate what is progesterone's, this prometrium effect on the breast tissue. I can't tell you, does it increase your risk of breast cancer slightly, or does it have a null effect? Because we really need those quality studies. And that's, I'm hoping, what in the next, couple decades to come, we're hopefully going to be able to get.
Yeah. Let's hope we continue, clinical research right now during our current administration for women's health.
Yes. I have a shirt coming in the mail today. I'm waiting for it. And actually is a shirt that says, like, I don't know, I'm such an Instagram buyer. It's so bad. But I get this shirt that's called Girls Just Want to Have like Funding for Scientific Research. I love that shirt. I'm about to be delivered today.
That's
right.
cute.
We've been ignored for too long. I feel
right. And I know,
And
I know you touched on this like a little bit, but I mean, how does, and I think people don't know this either, of like how menopause affects your overall health, like heart health, your density, metabolism.
Yeah.
And, not just.
Isn't your heart health like the number one killer, or
heart disease, right?
Or cardiovascular of women, not breast cancer, but that's all you talk about.
I feel like I talk about that all the time on Instagram, that heart health is so important. It's the number one killer of men and women, but it's the number one killer of women. But for some reason, and I think I even talked about it last night on the Super Bowl, they did two commercials. They ran a commercial for breast cancer, which literally I had 12 people here and everyone in the room was silent because it was 100 pictures of women's breasts in different things. And everyone stopped and was watching. And I had, two breast cancer survivors in my group and everything. And I said, I don't think breast cancer is the point was of the commercial that, we're not giving enough attention to it. I'm like, I actually think we give a lot of attention to breast cancer. And I think women are so scared of it. Everyone stopped and watched this commercial. And then 10 minutes later, there was actually a commercial on heart disease. I don't think anyone even noticed it was on. And I think that is I think that is ignored for some reason. Women are not as scared of it, even though that is the number one killer of women. So yes. And it is so important. And one of the focuses of my practice actually is going to be, really understanding what a woman's cardiovascular risk is. Because to get to your question, Tara, there's so many health changes that happen to us through the menopause transition and once we lose that estrogen. And yes, one of them is heart health. Like, our cardiovascular risk prior to menopause is lower than a man's cardiovascular risk. But the minute we hit menopause, now all of a sudden we're on even footing with men as far as what is our cardiovascular risk and risk of heart attack. So, really our whole lipid profile changes through menopause. So, we'll see our cholesterol shoot up. Our metabolic profile changes. We'll see our risk for diabetes go up.
Blood pressure, blood pressure went up.
Absolutely. Yeah. Lipids, high blood pressure, cardiovascular risk, metabolic disorder risk. And we see other changes happen. Our we start losing our bone density. We start gaining weight in unhealthy areas like our abdomen, and we gain what's this very dangerous fat called visceral fat. Visceral fat is fat inside our abdomen that surrounds our visceral abdominal organs, and it's inflammatory. So it will cause inflammation surrounding all of our abdominal organs, which is not good. It's dangerous, and we have to learn how to exercise and change our diet to keep that from happening. We have we have a different hormonal balance after our estrogen drops. Our estrogen takes a very precipitous drop at menopause, right? Versus our testosterone, and we always have testosterone in our bodies since we were born. And our testosterone goes down very gradually from the time we turn 25, and every year it goes down really gradually. But our estrogen takes a plummet at menopause. So the balance is different. We used to have much higher estrogen to testosterone balance prior to menopause, but then once we are in menopause, we're a little bit more testosterone, or what we call androgen dominant. So estrogen creates a distribution of fat around our hips and our thighs and our butt. Testosterone, as you can look at a man, you see where the male distribution of fat is. That's around their abdomen. So that's why we start seeing this different distribution of fat. And and hormone replacement therapy can help moderate this, and help in where that fat gets distributed. It certainly helps with our bone density. We know that's an actual FDA approved indication for using hormone therapy. It will help with our maintaining our metabolic status. It helps prevent, diabetes and things like that. And it's certainly, there's a lot of research that absolutely points to the fact that it is going to have a cardioprotective effect.
Yeah.
So it's not currently indicated for cardio prevention, but you can't deny the fact that it is absolutely going to help decrease your cardiovascular risk factors.
Yeah.
That's so much information that people don't know.
Yeah.
You know what I mean?
You have to be an advocate for yourself.
I meant it's great. It's helpful. I just, this is why we want to do this, because I feel like it's so important, everything you said, for women to know that, because they don't realize what all goes in hand with menopause. And,
I mean, I am anxiously awaiting I just had my physical. It's the first year that I'm going to have all my lipid profile tested, having been on hormones for a while now. I'm happily taking hormones. I really feel like you're going to have to bury me with my hormones. I don't really have a plan to go off them. I don't feel like there's an end point for me. I feel like they have changed the way I feel. I didn't have a plan to start hormones. I was going to wait and see how I feel. I feel like a lot of women, come to me with questions about when should I start. That's another misconception, that you have to be in menopause we should talk about definitions too, but you don't have to be in menopause to start hormone therapy. You can start hormones when you start feeling symptomatic, and that's the most important thing. But you don't have to start before. If you're not symptomatic, that means your hormone levels are fine. You're not having problems. But if you start feeling like my sleep is affected, I'm getting hot flashes. I had a friend approach me. She had questions because she wasn't really necessarily bothered with hot flashes or night sweats, but she wasn't feeling herself. She was in her late 40s, and things just started getting bad for her, like her mood, her feeling of, chronic fatigue, or her energy level. And I said, talk to your doctor, get all the things checked out, get your thyroid checked out, get your vitamin D levels checked out, all the things, that other reasons that it could be. But if everything else checks out, this could absolutely be perimenopause, and you don't have to have a hot flash or a night sweat to be perimenopausal. And she did end up going on a form of hormone therapy, just birth control. It feels like feels like she's back to herself, feels great. And she has her energy levels back, and she's working out again. This was a common thing that I hear. A lot of women, even on my social media, come tell me that their doctor said, you are not in menopause, you can't be on hormone therapy. And that's 100% not true.
Right. So what do women do when, you want to get all these tests done, and your doctor you have now may or may not do it? Like, they might be like, no, you're fine.
I mean, I personally, listen, I don't believe in saying ever that your doctor is bad, or this and that. But not doctors have training in menopause. Like we said before, most doctors and all the big influencers say it too. We all know that we don't receive this training in in medical school, and we don't even receive it in an OBGYN residency. So I think things like that are going to be changed now. I certainly devote a lot of time towards resident education, and I want to get the word out. But if you have a doctor that, is not receptive to testing you, you have a couple avenues. You can bring the research to your doctor, which may or may not upset your doctor. But if a patient ever brought in research to me, I personally think that if you upset your doctor by bringing in certain research, then you may need to find another doctor, because as a doctor, we should always be committed to continuing learning, continuing medical education. Okay. And there's always things that we may not be aware of. Now, if someone's bringing me bad science, then I want to read it and I want to tell them it's bad science for X, Y, and Z. But if someone's bringing me good science and I was unaware of it, I want to read about it, know about it, and then thank my patient for bringing it to me, and then I want to be able to act on it.
Yeah.
So if your doctor is not open to what you have to bring them, then that might not be the right doctor for you. If your doctor's open to it and is able to see that this is actually based in good research, then they should test you. And if you need to find a provider, if it turns out that doctor's not working for you, you need to find a provider. There are providers available on a couple different places where I point patients. One is menopause, www.menopause.org. That is the Menopause Society's website, where they do have a list of providers that are registered with them. Not all of the providers there are actually certified menopause providers. The ones that are sometimes like I list in my bio there, I'm a certified menopause provider. Some are not, but I feel like if you're on that website, you should at least have an interest in menopause and know about this stuff. Right. And then Mary Haver on her website, The Pause Life, she doesn't have, it's not necessarily certified providers. Her list is made up of providers that patients have written in about, providers that have helped them through menopause. They're not vetted. I don't think they're just patient vetted. And so I do sometimes wonder, are these providers people that have been giving their patients testosterone pellets or other modalities that I don't personally approve of because of their safety? But they've at least been recommended by patients as menopause sympathetic providers. So I think those are really good places to start. I also think that there's online resources like MIDI Health. That's MIDI Health.
Yeah, didn't you use that, Tara? MIDI Health?
Yeah. You gave me that. Yes.
MIDI Health, they're very well trained. And there's also another online resource called Jenna. That's JENNBV. And they're specific to menopause. So there are a lot of avenues where you can go to get a provider that's going to listen. But even that lab testing, that is basic stuff. Like the things that I check in patients, like sometimes I need to check hormone levels. Sometimes we don't need to check hormone levels. Like another misconception is that you have to have your hormone levels checked.
Yeah, mine before.
I mean,
it was just really, my symptoms, like you mentioned.
Exactly. Like by standard of care, if you have symptoms, you should be treated. And we don't always need to know your hormone. We don't need to know hormone levels to diagnose if you're in menopause or not, or perimenopause.
And don't they fluctuate a lot as well? So it's hard to really pinpoint it.
I think you could be giving this podcast because you know so much about this person. But yeah, that is one of the reasons why we don't need to check hormone levels to diagnose perimenopause. We can't. Hormone levels are a roller coaster in perimenopause, and we can check them one day. Your estrogen levels could be low, and then the next week they could be high and back in that normal range. So if you're having symptoms and you're in that age range, 45 to 55, that's a normal age range to go into perimenopause. And we should just treat you until you feel better. But if we suspect that something else is going on, you should have your thyroid checked and your vitamin D levels checked. And sometimes you need your B12 levels checked. Sometimes there's a lot of other things going on.
Right.
We have to make sure we're not overlooking something and just calling everything menopause.
Right. Yeah, that's true. And everybody's different. Everybody's
everybody's. I feel like I feel like the big surprise for me, menopause, was the mental health aspect, which I never had any issues with, and that's really how I start. Well, the sleep and things like that, but like a panic attack, I never had one before.
Yeah, I remember
in my life, and generally not a super anxious person, but
my own mother went to the ER 3 times for what she thought was a heart attack, when really it was just her going through menopause. I didn't know anything about it at the time. I was I just starting out in my residency, and 3 times I took her to the ER for palpitations and a feeling of just overwhelming anxiety. And every time her heart was fine, and it was really just going through menopause, but she was of the generation that never got treated. Hormones weren't a thing for my mother. You know what I mean? She used to strip down and sit on the air conditioner.
Yeah.
Oh my gosh.
That's how they thought they would cure it or, get through it. Yeah.
So
You
mental
know
health
what?
is a huge thing that panic
Yeah.
attacks, anxiety leads to depression. And actually
Right.
hormone therapy is a valid and research-based cure to, or I should say treatment modality to anxiety and depression for menopause. And if that doesn't work as an adjunct, SSRIs are like an added, an
Yeah.
added modality we can use combined with hormone replacement therapy, very helpful through perimenopause.
Yeah. I had to do both. I also truly do believe that, and I don't know, I've seen things because I've been on it, for estrogen for like a year and some change, maybe like 16 months. And she started me on the lowest dose and then bumps me up to the next one because it wasn't enough. And then when I have what I like to call my fall breakdown, where I don't know what happens to me, but
Sorry, it's not
I,
funny, but
I
just
literally fall during the fall, like
literally
somewhere
did.
around
Yeah.
October, I lose my mind. And, and she bumped up my estrogen again. But this is a question I have for you is that do people absorb because I'm on the patch, right? And I take the progesterone pill at night. I call it my sleeping pill. Do
Amazing.
people absorb it differently? Because sometimes I wonder if I'm absorbing it, like, because I was still having those mental health like symptoms, and I had to go on the SSRIs. And, I also
Yeah.
think lifestyle for me is a huge thing too with exercise and how I eat, so.
Well, you said before that everyone is different. And one of the reasons why actually menopause is difficult to or I should say perimenopausal symptoms or diagnosing it as perimenopause is difficult is because everyone manifests perimenopause differently. Some women have the obvious hot flashes, night sweats. Some women have none of that, but it's their mood. Some women have joint aches and pains everywhere and they don't know what it is, but you give them estrogen and it goes away. So yes, people do they react differently to perimenopause and they can absorb estrogen differently. I started with the patch and that actually transdermal forms are supposed to be very good for the mood symptoms. But I started with the patch and it actually didn't really even, work very well for me. And there are a percentage of women, I think it's something around 15 to 20% of women may not actually absorb it very well transdermally. So I did go to oral and all of a sudden everything was fine on the oral. But, I think women need different dosages depending on, on what their body's doing. Like I don't typically start a perimenopausal woman like in their late 40s and early 50s on the lowest dose
Yeah.
because their levels, they're going to need more. Their levels actually are already a little bit higher than a woman that I would start at the lowest dose. Like if somebody came to me at 65 and was having symptoms, that's a patient that I want to be a little bit careful on because the benefits aren't there for her as much as the benefits, like the protective benefits that we were talking about, aren't
Right.
there for her as much as the woman that started within a 6 to 10 year window for menopause. And the risk for her to start is actually a little bit higher. So for women like that, I want to start them on the lowest dose. And they probably will be good on the lowest dose because their estrogen levels are even lower than someone that's 50. So for someone that's just coming to me right in perimenopause, I usually never start them on the lowest dose because there's not as much benefit to giving them a teeny tiny baby dose. And there's also not as much risk for them starting a higher dose because they're younger and healthier with no
Right.
pre-existing vascular disease, presumably. So I start them in the mid range and then I see them back and I say, like, how are you doing on this? If they need more, they need more. If they're fine, I keep them on that dose. And then maybe if they decide they want to stay on it until their later years, that's when we would have the discussion about you probably could move down on this to maintain yourself on the safest dose.
Right.
And
Right.
so, yeah, everyone is different. I think it's depending on what their own body is doing.
Yeah.
Yeah.
Well, I was like a frequent
Right.
flyer. I called, like, I used to say, but my daughter was a frequent flyer to the nurse. And then now
That's
I'm a
right.
frequent flyer. I'm like, I have vertigo. I'm having a nervous breakdown. Every week I go, I have hives. I have hives. I had like
Yes. Oh my
these
God, the
acute
hives.
hives for
Yes.
like 8 weeks.
Oh my
And
God, they were
I
A
swear
lot
that
of
had something to do with
conditions
it
can
because they would come during the day.
it's
Some days they
insane.
didn't come. Some days it was like a job. And then some days they would come at 10 a.m. and leave by 5.
Yeah.
And like it was bizarre. Like
I mean, I
It
think
was.
perimenopausal care can go in a number of ways. I've had patients where I've started them on hormones and I make them come back for the 3 month checkup and they're like, Doc, I am great. You cured me. I'm good. And I'm like, all right, then you know what? See me on an as needed basis, and I don't see them until next year for their annual. And then I've had patients where I expect that, I've had to see them 6 or more times a year, just depending on if they needed a dose adjustment, if they needed an addition of something else like testosterone, or if they had other symptoms that popped up. So like, I think, in my new model, in the practice that I'm like my dream practice, I'm gonna anticipate that these patients might need some more intensive care and therapy. You know what I mean? They might need 6 visits a year, and that's good.
Yeah.
Yeah.
And I did
Yeah.
I did test the testosterone, which by the way,
Uh,
insurance doesn't cover. Lovely.
no, it
Yeah.
does not.
Yeah.
Yeah.
I'm like, what I like called them, I'm like, I'm a 51-year-old woman. Like my hormones aren't covered to get checked.
Right.
But no, they're not. But
They're
I did
not.
go on the gel, the transdermal
Yeah.
gel, in the,
Yeah.
preparation that someday I'm gonna have sex again.
I knew you were going to say that. I knew
So
it. I
no,
knew
as soon as my daughter
Actually,
gets out of my vagina and then, and my bed.
get the for sex, if you're it's I mean, we're talking about libido for testosterone, and we're talking about estrogen
Like
for
vaginal estrogen.
vaginal health. Yes,
Yeah.
vaginal estrogen. Actually, even systemic estrogen that you're taking, a
Hmm.
lot of women that are taking systemic estrogen will not need the vaginal estrogen because that will have an effect on your vagina. But if it, and that's great. And if it doesn't, then you can add the vaginal estrogen. And that really helps take away dryness and a lot of the pain that women in menopause experience with sex. And sometimes that's enough. Like generally, when women are having issues with painful sex, we know it's vaginal estrogen, dry vagina, vaginal estrogen, and sometimes even libido issues. We generally start with traditional hormone replacement therapy first, estrogen, progesterone, and we give that a shot. And if that doesn't work and they feel like they need a little bit more, then testosterone is indicated for low libido.
Okay.
All right.
We see how
Okay.
Well,
that works.
we love their Instagram about the toys too.
Right. Right.
We're like
Yeah.
loving that, right?
Yeah. Because you got to work it. You got to keep it alive.
Yeah,
And
I think mine's dead. I don't know. I think it might have dried up. I don't know. I don't know. I'm hoping that like the third part of my life is just a killer, like, I don't know. The
I
first two
mean,
parts
I
sucked.
will tell you, I do think that there are 2 things on that. If you want to see more about sexual health and wellness, you definitely will have to stay tuned to my Instagram through the end of February into March because I'm going to the Ishwish Society meeting, which is the International Society of like Sexual Health and Wellness. It's basically like sex medicine.
Love it.
So there's going to be a whole lot of toys and stuff happening. And then I do think, yes, you don't ever think midlife and the last third of our lives is going to be something where we're just going to like shrivel up and die and become useless.
Yeah.
I found that not to be true at all. Like, I feel like, as my kids get older, I have one off in college. I have one still at home with me that drives and like doesn't really, she wants to hang out with me sometimes, but mostly it's about her friends. So it's like, I have like so much more time and
Yeah.
time for self-care and just time in general that I never had when they were in diapers and I was like a single parent. I was working 90 hours a week. I have time to like really take care of the things that I need to do for myself with my health, with working out, like even just having that time creates, I think, a more vibrant picture of myself, a more hopeful picture of the future. And this does not have to be a time when we are just
Yeah.
unhappy in life and not doing this. It can be a time for self discovery, a time for travel, a time when
Right.
we're financially more secure than we were before.
Yeah.
And
It
I
could
think
be
it
the
could be
best
like the
time of your
best time.
life.
Yeah.
Yeah.
And
Because
that's
like you don't care. You're just, I feel like it's like a metamorphosis. It's like a rebirth because I did see it as a reel that says like, I guess maybe when your hormones come in puberty or like brain starts working more towards like relationships, right? Come our driving force and maybe connection, the chance that you could be a mother every month. But then when your estrogen is
when that's gone.
leaving, you're like, what the I did my whole life. I'm like, and now you have no more fucks to give for anybody.
Right. Right.
Your fucks are gone and you're like, who am I? What
Right.
do I do for myself? Like what? But it's very empowering too, even though it feels like you're off, right? Like you don't feel like yourself, but you're like, who am I self? Like I've
Oh,
spent
shoot.
my whole life, I've, done for others and worried about that. And now I'm like at a place where I'm like, all right, this is going to be the best part of my life,
Yeah. And that's what, like, that's, we want it to be. But then we have all these other issues, I guess, to say that start. And you're like, oh my God, I thought this was going to be the best time and it's going to be easy. But now with all this help and education, I think it will be, or
I
it
think
can
when
be.
women start running into health problems, you have to find a provider that's able to help you. And once you can get through, like when you can start physically feeling better and start emotionally feeling better, that's the time, that's the good time. You know what I mean? Like
Yeah.
I definitely went through a period where I'm personally, my kids and my husband were like, what is wrong with you? Like, I'm not an irritable person. I all of a sudden noticed I was a short fuse. I was snapping. I was grouchy. I didn't like people and I wasn't sleeping. And a lot of that can be just from the sleep. You know, if you're waking up with hot flashes or even if you're not having hot flashes, quality of sleep is affected in perimenopause.
Oh, yeah.
So whatever you can do to get back, you know, that sleep quality and, you know, if it's hormones, if it's non-pharmacologic therapy, that's fine. But like, you know, you will get back to yourself and into the future. Perimenopause doesn't, for most women, does not last forever. Okay. And, you know, they have like done studies on women that are like further into menopause. And you do, whether you use hormones or not, you pass through perimenopause and actually happiness scores that have been like studied are higher in women that are like in their 60s that have passed through. They have, you know, like a lot more time, like we discussed. And so it's a temporary phase that you pass through. And then generally life lightens up and things get good again. So, you know, but I do think it's important to get the care that you need when you need it. And then
Absolutely.
things get better.
Yeah.
Yeah.
Now,
Absolutely.
besides the, hormone therapy, like what other things do you recommend, like
Mm-hmm.
lifestyle wise or anything to like manage your symptoms?
I think that, okay, so if we're talking about like putting hormones aside, there are a few non pharmacologic things that can be, like I say, holistic things. Like they're still pharmacologic, but like, you know, people want to know about supplements. So I say, like, listen, make sure your vitamin D is optimized. Make sure you're not iron deficient. So sometimes, you know, you need to take your iron. Sometimes you need to take your vitamin D. Sometimes you need to take magnesium, which helps you sleep. And then the other things that are so, so, so important. And listen, being a very busy person with a job and two kids and things like that, I get how hard it is to fit all these things in. But you have to do the best you can to get in the exercise that you need and to change the way you're eating if you're not already eating in a way that's going to help your health. Okay. We have to start thinking like, I wish that I had known all this and been more cognizant of it when I was in my 30s, because really that's the time that you have to start preparing for like the rest of your life. But like 50 is not too late. So you have to know that like I say I'm never going to be able to recommend a specific diet plan for anybody because there's so many out there and who knows what the best one is. But I do think that, you know, one of the universal truths about cleaning up your diet at any age, and especially as we get older into midlife, is cutting out ultra processed foods.
Mhm.
Because I think we're really being semi poisoned in America, right?
Totally,
um,
yes.
you know, and I've had patients that have like cured their autoimmune. Like I had a woman that came in and she had an autoimmune condition of the vulva that I tried to treat with steroids. It wasn't working, and we were about to move to a chemotherapy cream for it when she had a family member that died in Italy, and she went to Italy for that funeral, and all of a sudden it completely went away. Why? Because the wheat products there are different. You know, their additives are different, things like that.
Wow.
And, you know, that she kind of diagnosed herself like that. So anyway, not to get into that, but I do think we have to, you know, make sure that we're eating as healthy as we can, cutting out a lot of the ultra processed foods and sugar.
Hmm.
Unfortunately, limiting and or cutting out alcohol, which I know is like I know from the movie that we did, Kristen, the movie screening, that you know, you tell women to cut out their alcohol and we got a big groan in the room. But like let's
Yeah.
just not say cut it out. Let's just say like be
Cut it down.
aware of
Just dial
how
it
much we're
down.
drinking. Dial
Right.
it
Right.
down. It's the Surgeon General warning coming out saying this is a carcinogen, like
Right.
stuff
I
that is
know.
really not like good for you. We don't smoke. Why are we drinking on a daily basis? We shouldn't be doing that. And the diet that's recommended, at least, you know, the one that was discussed most when, you know, the latest Menopause Society meeting is really the Mediterranean diet, right? So if you can follow some of those basic rules and do the best you can, like no one's perfect. I struggle with like, you know, like diet myself. And I just say, I'm going to like endeavor to do the best job I can. And I'm going to make little steps
Little
forward all
steps.
the time. Exactly.
Right, right,
You
right.
Yep.
know, don't try to like, build Rome in a day. Just try to do the best you can. Change one little thing at a time over a long period of time. And that will be much more effective for you. And don't think in terms of losing weight, changing your diet to lose weight and be thin. Then think in terms of
Health.
your
Just
overall health. Because that
Right.
actually has been shown, if people are thinking about it in terms of their health versus thinness, it actually has much more stick to itiveness. right?
Yes.
Right.
Yeah. And that, oh
Yeah.
my gosh, that could not be more true, doctor, when you said that about Italy, because I just went to Italy with my family and me and my daughter Marley, like whenever we eat, I feel like especially we get a little pasta belly or something, or my belly's always swollen. Hers is little, mine is not. But when we went to Italy, nothing. We were both like, oh my God, we just ate pasta. I drank wine, which I normally am not a wine drinker, and I felt completely fine.
Really fun.
It was insane. I'm like, can't we bring that here then? Like, why can't we have that here?
Yeah.
All the good food.
I know,
Actually,
right?
the same way when I was like in France and Italy, the wine affected me differently,
Yeah.
and the carbs affected me differently.
Yes, it was
Unbelievable.
I'll go.
crazy. Yeah, I know. Let's just live there. Let's go.
Let's just go move there.
Yeah, right,
We
right.
might have
I
to move
know.
somewhere else.
I can't I can't live without my carbs. I can't live without my pasta, but
You don't have to, and you shouldn't.
Yeah.
right.
But I do think that like the motto that I try to live by is like understanding how to do these things in moderation. Like you should have carbs in every meal.
Hmm.
Carbs help you process all the other things. It also helps you with a feeling of satiety. Every meal should include a protein, a healthy fat, a carb, and then you're going to find yourself looking less for other foods and cravings until your next meal. You know what I mean?
Right.
Right.
It's a
And I think
balance.
exactly. And I think the other component to like what we need to do is, as far as exercise goes, is that we have to de-emphasize, not exclude cardiovascular, and we have to work a little bit on what's going to be building our muscles, because one of the things that I didn't mention before that happens, that the changes that we talked about with menopause is that we are losing our lean muscle mass as we lose estrogen. So we are really losing our muscle. So we have to now work at maintaining that muscle, which means eating the protein that helps build muscle and doing the exercise that helps build muscle. So you don't have to be like deadlifting 200 pounds,
Right, but
but you
some
have to be
strength.
doing things, strength training, to the point where you feel like your muscles are tired in not a million reps. I generally
Right.
say like 8 reps, 6 to 8 reps should make your muscles feel tired before you have to stop. That's great because it doesn't take that long to do it. And, you're building muscle, which is going to help you build your metabolic rate, keep that up so that you're not going to be losing, like you're going to be burning more calories, and you're going to be protecting your bone and your muscle.
Yeah.
Absolutely. Yeah. I'm learning that too, to do a little bit of strength training and not as much cardio, because you think you need, cardio is great, but you have to add the strength into it too.
Yeah.
Cardio is great
Definitely.
for your cardiovascular system.
Right.
Training is great for all the other things in perimenopause.
Yeah.
Yeah. Yeah. Absolutely. Yes.
Was there anything else that that we can leave people with during this time of their lives?
Right.
Honestly, just knowing that this is not the end of the road, this is not like a dead end, and there's like plenty of good stuff out there to be found, and it could be, and it can and will be like a really wonderful part of their lives. They just, have to like know that the help is out there.
Right. And that's what's so important, where you don't want to feel alone, or maybe you don't want people to feel like, is this just me going through this? Oh, I'll just ignore it.
Yeah.
This is so good where people can learn.
I mean, community is so important. Like, I obviously I'm in a different position because I'm a gynecologist. So people talk to me about things that I hear people don't always talk about. Like, of course, people always talk to me about like their sex issues. I have sexual, like, things about it. People talk to me about menopause all the time, strangers, friends, and family. So I'm in a little bit of a echo chamber. So I don't really know what's going on out there. All I know is that everyone talks about menopause and everyone's a menopause expert. But then I'm always a little shocked and in disbelief when I have women contact me and hear what they've been told by their healthcare providers. So I think that, I do think that it's good to talk to your girlfriends about it. I think there's like a whole section on, like, I joined a Facebook group that is about like women lifting weights and building muscle, and it's like over 40. And it's like 80% of the questions are all about menopause and perimenopause. So there's people out there talking about it. There's even an over 50 section on TikTok. So like you can find your people. You should be talking about it with your girlfriends. Don't be embarrassed. Don't be ashamed. Like, part of what I want to build in my practice is like a sense of community with its like small group training sessions, whether it's walking, hiking groups, whether it's like just coming together for like a monthly, people that want to meet and talk about it in a group with not just me, but with peers,
Right.
because you're not alone. Like everyone goes through it. It's a rare woman that does not notice the menopause change.
Yeah.
Yeah.
Everybody goes through it,
Yep.
right? Not everybody
Yeah.
may have a child, but every woman will go through menopause.
Right. Right.
You have to go through menopause, die, and pay taxes.
Yeah.
That's about it. That wraps it up.
That's it. That's life right there, wrapped up.
It's life
Well,
in a
thank you so
nutshell.
much for
Yes. Thank you so much.
spending your time.
Sure,
with
I
us.
love talk. Listen, like I'm so glad that I found something that I'm so passionate about that I don't get tired of talking about. So it's my pleasure.
Oh, thank
Yeah,
you.
I
That
know
was
it is
great.
such an important topic.
It really is.
Thank you guys for taking an interest in it and talking about it.
Yeah.
Oh my God,
Yeah,
yeah.
absolutely.
Yeah,
I love
I
it.
think it was our inspiration for this whole full Vagine,
Yeah.
our
Yeah.
experience in this.
Definitely.
For work. Keep up the strong work.
Thank you.
Thank you.
Yes, and good luck with the Menopause Collective.
Oh yes.
Yes.
You guys want to follow me and get a lot of good menopause and perimenopause information on Instagram right now. It's just Kim Einhorn MD.
Yeah,
Yes.
we'll share your
And
handle.
then share that. And then there's also a link that if you are in the Philly area and you want to get a information in your email about when the practice may be opening, you can always sign up there.
Awesome.
Perfect.
Yeah, we'll include all this, when we
Yeah.
publish the episode. So.
Thank you.
Absolutely.
All right. Thank you
So
again.
exciting. Yeah.
Have a good one.
All right. Thanks. You too.
Thanks. Bye-bye.
Bye.